what we have looked at, specifically prior to surgery, a lot of patients do have issues with bowel function, malabsorption, the anticipated weight loss, particularly if they're undergoing chemotherapy. So we try to optimize that as best with our oncology dietitian as well as our nutrition team to help just optimize patients. There's no specific dietary limitation prior to. Post-operatively, a lot of it does depend on what we end up doing through the surgery. So if we end up having to do any specific bowel resections, things like that, those are areas where we may modify the diet. Most of our patients end up eating solid food after surgery. It's just that we end up modifying the diet so it's less bulky, things like that. But ideally, I think nutrition is a key component to not only recovery, but pre-operative optimization. I will say that there's not a lot of specific dietary limitations that would necessarily make a difference one way or the other. Ultimately, when we talk about quality of life and what we've done with a lot of other different surgeries that I do, namely esophagectomies, pancreas surgery, things like that, is that we've looked at what we call enhanced recovery pathways. And those are things that we're looking at implementing with Hipec in terms of an evolving protocol where we recognize that patients ultimately will have lower risks for complications, improved quality of life. And two of the main things that happen with that is if they're fed early, meaning that we don't necessarily need to wait for patients to start to have bowel function, pass gas, things like that, but we advance the diet pretty quickly and minimize the use of NG tubes, which are decompressing the stomach. And those things do show that patients do regain bowel function faster, and as a result of that, they stay in the hospital fewer days than those that are not. So although that does translate again to some of the dietary questions, what patients have taught us, essentially, that do this operation, is that they can recover faster, that we don't need to clinically make the decisions that say, well, you're now having bowel function, so let's advance your diet, is that we can allow that patient to trial the diet a lot faster and not limit them, so to speak, because it is a key component to how they recover.